Hello friends, welcome to the EM webinar series on the topic GI emergencies. My name is Dr. Krishna Prasad and I'm currently working as a senior clinical fellow at Luton and Dunstable Hospital in the UK. The question for discussion today is, what role does vitamin K have in the treatment of acute upper GI bleeding, the indications and the cautions? As you're all aware, vitamin K plays a key role in the management of upper GI bleeding, especially on patients on anticoagulants such as warfarin. So in this short webinar, what we're trying to deal with is we look at the basics, go through a bit of literature review on the studies which mentions vitamin K as a treatment options, and also talk a bit of the cautions, what you should be really careful while giving these drugs. So let's go to the basics first. Vitamin K exists in different forms. So you have the form called vitamin K1, which is the most natural form or the plant form. And you have the vitamin K2. Now, this form is usually it's a converted form. For example, it goes into the K1 gets converted to K2 by the gut bacteria. And also there's a mention of a form called vitamin K3. It's a synthetic form. So what is the mechanism of action? So in our body, you have this vitamin K dependent factors which are parts of the extrinsic pathway, like you have factor 2, 7, 9 and 10. Now most of them exist in a hypofunctional state. Now I think I will show you the next slide. This will give you a bit more clarity. Now you have the hypofunctional factors. If you look at the bottom of the slide, 2, 7, 9 and 10. Now they depend on the enzyme. They need carboxylation to become functional. So they're dependent on the enzyme called vitamin K dependent carboxylase. Now if you look at the top, you see the warfarin. It inhibits the enzyme called vitamin K epoxide reductase. That's the one which provides reduced vitamin K to the whole reaction. Now keep in mind that vitamin K it's a coenzyme that involves only in this particular reaction, okay, and therefore it's only beneficial for patients receiving warfarin and not for any of the other drugs, any of the other newer anticoagulants or the directly acting inhibitors. Now this is a very interesting slide. So you see three key players there. So if you're thinking in one context, you might say that it's the cardiologist who is producing the bleeding. I'm giving an example of an upper GI bleed on anticoagulants because he puts the patients on anticoagulants and eventually the adverse effects includes bleeding. And then you have the gastroenterologist who receives the patient at the end, okay, if some complication develops, who tries to stop the bleeding. You have the hematologist at the corner who tries to be helpful. Helpful in the sense that he's not available all the time, but he's able to give advice over the phone. And eventually you have the emergency physician in the middle who eventually has to coordinate among all these people, and also he has to receive the patient at his most critical stage. So it's a very coordinated fashion in which we deal with all these emergencies. Now this is a very interesting, in my search for literature to find a clear evidence of what vitamin K has a particular role. So I found that this is a Cochrane database of systematic review. So basically this is an association which looks into all the reviews across the world and comes to a proper conclusion. So they found no randomized clinical trials involving vitamin K for upper GI bleeding in people with liver diseases. So at the moment you can't say that whether it has benefits or harms, but at the same time we cannot recommend or refute the use of vitamin K in patients coming with upper GI bleeding and liver diseases. But at the same time, we have the pharmacological basis which supports this. Now, I have thrown two questions on the slide. The first question is, what question should an emergency physician keep in mind regarding upper GI bleed? And the second one is, when should you call a gastroenterologist and what does he or she want to know? Now, if you look at the questions might sound different, but the answers are pretty obviously the same. So, for the first question, which we need to answer is whether this patient is having a life-threatening bleed or not. I'll be giving a little more detail in the next slide. And also you need to know what are the comorbidities. If you look at the statistics, more than 30% of the patients who are presenting with acute upper GI bleed has one or more kind of liver disorder like cirrhosis. And also you need to know the markers of the extrinsic pathway, such as you need to know your prothrombin time, the patient's INR, and also you need to know which anticoagulant is the patient on. Now in India, the most commonly used anticoagulant is warfarin, but also the newer ones are coming up slowly. And also you need to know the reasons, why this patient was put on anticoagulant in the first place. Whether this patient has got any history of atrial fibrillation, any DVT, any PE, any thrombosis involving the mesenteric vein or the cerebral sinus, or does the patient have any metallic heart valve, any ventricular assist devices, or the patient is having any, like an APLA, antiphospholipid antibody syndrome. And also at the end, we need to decide whether this patient is having a high risk or a low risk. You can use the prognostic scoring scores such as Roccal score or Glasgow-Blatchford score. Now, it gives a pretty rough estimate whether this patient has a high risk of mortality, rebleeding, or any other complication. Now, yes, that's what I'm coming with. So we need to be very clear as an emergency physician what is the life-threatening hemorrhage. Now, in the context of upper GI bleed, it's a patient with upper GI bleed which is having a hemodynamic compromise. That means maybe his airway, breathing, so everything might be compromised. He will be actively bleeding, okay, and his blood pressure will be less than 90. And if you put a Foley's catheter and check his urine output, there will be nil urine output. So yes, our instincts are coming up. Okay, so the first thing, resuscitation. Okay, go by your airway, breathing, circulation. If the patient is drowsy, going to collapse, or he has potentially going to collapse, you need to secure the airway, you need to put him on oxygen, and you need to deal with his circulation. Of course, he will need blood transfusion, but by then you can start giving him fluids. Follow the institutional protocol. Maybe some hospitals may have some policy for a massive hemorrhage transfusion, or you can prescribe packed red blood cells like 4 at a time, or just see how the response is. And also, if the patient is on anticoagulants, you need to treat you need to think in terms of the reversal of INR also. Okay, now I'll be going in a little more detail here. So, first thing, as I said, fluids and get the bloods faster. Okay, the second thing is that you should not look at the hemoglobin level at this time. Okay, now if you have the nurse or the resident comes up with a VBG or an ABG saying that, doctor, the hemoglobin is 10, I would say don't look at it, because here we have a patient with a life-threatening hemorrhage. We should never depend on the hemoglobin level which has been shown up in the result paper. And also, if you're looking at the anticoagulant reversal, we have a little bit of options here. Now, as I said before, the most common used drug is warfarin. So we have a little bit of options here. We have vitamin K, we have fresh fluorescent plasma, and you have the prothrombin complex concentrate. Now, I'll be going one by one in detail. Then we have the newer oral anticoagulant drugs, or the directly acting oral anticoagulant drugs, NOAC or DOAC. So you have the examples like dabigatran. Now, there's only one FDA-approved drug for dabigatran. I mean, in terms of the newer ones, there's only one FDA-approved one, that is for dabigatran. That is called, it's very difficult to pronounce. I found a little bit time to pronounce it. Idarucizumab. Now, there's some YouTube videos which helps you to, get a good pronunciation out of it. There is a drug called andexanet alpha for edoxaban apix, but it's still not approved yet. And also there's some new literature which says that aripiprazine is a universal antidote for thrombin and 10A inhibitors. Now, I would like to bring your focus and complete attention to this particular study. Now, this study was conducted in Spain and was published in the New England Journal of Medicine. Now, this is a very good study, okay? They found that, they wanted to get a cutoff for the hemoglobin level to see how to transfuse, blood, what should be the cutoff. So they studied around 921 patients who are presenting with severe acute upper GI bleeding, and they wanted to know whether it's a cutoff of 7 which is better or a cutoff of 9. They use the term something called a liberal strategy and a restrictive strategy. So less than 7 goes to the restrictive strategy group, and less than 9 goes to the liberal strategy group. And they found out that as compared with a liberal transfusion strategy, a restrictive strategy significantly improved outcomes in patients with acute upper GI bleeding. But at the same time, what I want you all to focus is that one of the exclusions were massive bleeding, and that means I would interpret it as a upper GI bleed with a hemodynamic compromise. So do not use cutoff based hemoglobin levels for the management of such patients. So this algorithm is pretty simple. So you have a patient coming with upper GI bleed. I'm also talking broad in terms with anticoagulant use. So you have a patient who is life-threatening, in that go for resuscitation, go for blood transfusion, and think in terms if the patient is using warfarin, okay, you have these options with you. You have vitamin K, but the thing is that vitamin K, if you give it, the action for the action to peak up, it takes around 4 to 6 hours, okay. But the thing is that it's a sustained action, so that over 24 hours you get the reversal. The best agent is PCC, or prothrombin complex concentrate. You get INR reversal within 10 minutes, okay, but it's short-lived. You might need to repeat it after some hours. And then you have fresh frozen plasma. The guidelines say that if PCC is unavailable, you can give FFP, but it only provides a suboptimal correction. It takes a little more time. It may be 1 to 2 hours to peak up, and it goes sustained till 9 hours. Okay, and I know most of the hospital don't have the newer reversal agents, but still that's an option. And also you need to go for the endoscopy as early as possible. If the patient doesn't have any life-threatening hemorrhage, in that case you can use the risk assessment scores to decide whether this patient is having a high risk or a low risk, plan for endoscopy, and give blood transfusion if the hemoglobin is less than 7, and give vitamin K according to the INR levels. Now, vitamin K, having said so, at the same time you should be a little bit careful. Okay, there's some situations, for example, when you're starting to give warfarin, it takes at least 5 to 7 days to reach your therapeutic INR levels. But if you want to stop them, for example, to bring it back to your normal INR levels, you just need to stop it for 2 or 4 days. At the same time, there are certain patient population which you can't afford to bring the INR to the normal levels for a long time. One of the examples, the patient on mechanical valves. But if the patient is having a life-threatening hemorrhage, the situation is different. You need to give these drugs. But always have a discussion with the cardiologist. The patient might need to be put back on the anticoagulants as soon as possible after the definitive management of the upper GI bleed. So yes, and I think there's also one more point which I forgot to mention. So if you go through literature, vitamin K has a very rare chance to go in for anaphylaxis. So what I would recommend is that you can give it slowly, and also mentioned with the IV route. So you can give it as a slow bolus or a slow, so that the risk is lower down. Well, that brings us to the end of the webinar. I hope you all enjoyed it. So if you have any feedbacks or any tips for improvement and stuff, please write to the email address given below. That's the end of it. Thank you. Have a great time.